Hi everybody, my name's Juanita Copeland and I'm very happy to welcome you to tonight's Fertility Week webinar entitled Advances in Embryology. I'm the National President of Fertility New Zealand, and for those of you who haven't had much interaction with us before, I thought I'd just give you a little bit of a rundown as to who we are and what it is that we do. So we're a registered charity and we're dedicated to supporting people facing infertility in New Zealand. And we do that in a few ways. The main ways are through information, support and advocacy. So we provide a lot of information, both written and on our Fertility New Zealand website, as well as running support groups around the country. And we also do advocacy for our members too if they require support in their clinic interactions or any other part of their treatment. So we've been around for about 25 years. We're the only charity that works in this space and provides support for people facing infertility and going through what can be an incredibly trying journey with a lot of speed bumps along the way. And we just feel support and information are two ways that can really help make this journey a little easier to bear. And of course, knowledge is power, and that's one of the reasons why, as part of Fertility Week, we run our webinar and events program. Tonight's webinar, we are very excited to share with you more information about advances in embryology. We have an amazing speaker, Dr. Debbie Blake, who's a scientific director for Repromed, one of the fertility clinics in Auckland. So without further ado, I will disappear and invite Debbie to jump onto your screen now and work through this presentation she's put together for you. You're very welcome to type some questions in the chat box, which will be on your screen. What we will do is just hold those back until the end of Debbie's presentation, and she will answer those for you then. So please feel free to be involved, and I hope you find tonight's webinar really informative. So Debbie, I will hand over to you.
Welcome. As Juanita said, I am the Scientific Director of Repromed, and it is my great pleasure tonight to share with you a topic that I'm obviously very passionate about. I've had an it's been my absolute privilege to provide over the last 30 years of my career a helping hand to help create some very precious babies over the years, hundreds of them now, which is a great privilege. Since starting at National Women's Hospital, which was New Zealand's first IVF clinic in New Zealand back in '87, I've certainly seen some tremendous improvements and advances in the technology. And that's what we're going to be discussing tonight. And to do that, I thought it's helpful to look back on some of the embryology, the history of it, and also what we're doing today and where we might be going. So with all good stories, it's nice to start at the very beginning and acknowledge the miracle baby, Louise Brown, that was the very first world's IVF baby, and acknowledge the incredible work of Robert Edwards, who was a scientist, and Patrick Steptoe, and their research over many, many years and hundreds of failed attempts before Louise was born. But I'd also like to acknowledge Jean Purdy, who's often missed off the history books. And she was the very first world's IVF nurse, and also Bob Edwards' technician, so the first female embryologist as well. And her untimely early death meant that she's often not acknowledged in this very important team that got this started. So here's a lovely photo of Bob Edwards 30 years later with Louise and her son as he's accepting the Nobel Prize, which I thought was a very long time to wait after such an incredible event on the world scene. Australia was quite quick behind, providing the third ever IVF baby back in the 1980s. And this beautiful woman here, Candice Reid, I've had the pleasure of listening to her speak at many conferences. She was the first Australian baby, and she actually works as an ambassador for IVF lings these days. New Zealand's first baby was back in 1984, and back then there was just one baby born every 3 months, which is a stark contrast to today, where we have one baby born every 30 minutes, IVF baby. And there's well over 7 million babies born now, and would you believe that 30% of them are able to vote these days? So I thought it might be quite nice to start off with the evolution of incubation, which of course is the core of what we do as embryologists. Our primary aim is to mimic nature. You know, we're trying to mimic what goes on inside the fallopian tubes in the uterus in a woman's body. So we're trying to optimize nutrients, gas, and temperature, obviously. And I just love this photo here of Louise holding up the humidity crib that was used, which she was spent the first 5 days of her life in. And when I first started IVF, these were still around in the incubators that we used. And I think maybe many of the young embryologists these days probably don't even recognize what this is. What they will recognize is the humidity cribs, which is what we use to handle the embryos in when they're outside of the incubator to keep them warm and at the correct optimized temperatures and gases. And back in the early days when I first started, we had a modified baby incubator from the intensive care unit at National Women's, which had been modified, and we'd put a microscope in it, which worked relatively well. And as just a quirky little side note, it was my father who had actually made the humidity crib back in the 1960s when I was a toddler. He was a plastics engineer and had first made these very early humidity cribs, which was really lovely to know that had happened. So back in those days, we cultured all of our embryos in test tubes, hence the name test tube babies. And we used to put them in these very large chamber incubators here, which, as you can imagine, every time you open the door, all of the gas and the temperature would rush out, and it would actually take a very long time for that incubator to equilibrate again and get back to normal. So what we do these days is we have these lovely benchtop incubators here, which has reduced the space down to a very small space for the air loss and temperature loss, and they're much more efficient. We culture our embryos now in these lovely dishes, and we use very fine glass pipettes to transfer the embryos around from one drop to another. And back in the early days, I used to make all of those glass pipettes by hand by pulling them out over a glass flame, which used to take, some people thought it was a very mindless job, but in fact, I thought it was really satisfying. I really enjoyed doing that. But we have the benefit today of buying and purchasing in all of the consumables that we use now, which already comes pre-tested. Originally, it used to take me a couple of weeks to make up culture media that the embryos would be grown in. And it was a very tedious process using mouse embryos to test each batch before we used them on humans, a process that I actually wasn't very keen on at all. But we have, you could call this one of the revolutions of embryologists, that we can now buy everything in pre-tested, and it's of absolute premium quality. We pay a lot of money for that, for all of that testing, but by gosh, it's absolutely worth it. Right, so where's the future going with embryo incubation? Well, I think it's time-lapse, and these lovely machines here, these time-lapse machines here, they'll hold up to 16 different couples or people's embryos, which get put onto a carousel. And The nice thing about this is that when we put the embryos in on day 0 or day 1, they stay in there for 5 days undisturbed, so we never have to get them out. Our current process is that we get the embryos out of the incubator every day, almost every day, and we put them underneath the microscope, and really it's just a little snapshot of time that we look at the embryo once and grade it each day. Well, the benefit of time-lapse, of course, is that every 10 minutes, every embryo in there gets a photo taken, and when you add all these photos up, it produces the most amazing video of every embryo's growth. So what's good about that? It's not just looking at morphology of the embryos, which change almost, they're so dynamic. They change the way they look almost every 10 minutes to 20 minutes, they look differently. But importantly, it gives us, it times every important event that happens over those 6 days. And those times have been correlated with viability. So all of that kind of data gets recorded. And these days that's called big data, where we've got all of that data collected around the world. And eventually this will, every embryo scope or time-lapse machine that you will purchase will have artificial intelligence guiding the embryologist as to which embryo is going to have the greatest viability when we put it back, which is, you know, an amazing revolution. The other interesting thing that I think is very important is that it can show us when there is abnormal fertilization, which often we miss because we're just looking at the embryo just for a very tiny, just a minute a day. We can often miss really important events that happen around fertilization. And I was going to show you some lovely videos tonight of some normal embryos developing, going through fertilization, and some fascinating abnormal ones, which we would ordinarily miss. But unfortunately, the webinar can't quite cope with the videos, but never mind. There is a link here, however, if you are interested. I don't know whether you'll have access to go back and have a copy that link, but there's plenty of links that you can go to on YouTube that can show you what time-lapse can show us as embryologists. As embryologists, we just love looking at these videos, and that actually can be quite time-consuming in itself. And that's where I think the artificial intelligence and the algorithms that are built up are going to make everything a lot more streamlined. So one of the big questions is, of course, because this kind of incubation equipment is probably about 10 times more expensive than the incubators which we use now. They're well over $3,000 worth of pieces of kit. The important question is, does it work? Is it of benefit? And there's plenty of clinics around at the moment that charge people for this extra added service that can be provided. But of course, we do need to know, is it worth the money? And so what we do as embryologists and scientists and clinicians is we do something called a meta-analysis. For almost every innovation and change in practice that we do, we will do a meta-analysis on it. And anyone can have access to this very valuable, very important pieces of work online. You can visit something called the Cochrane Library, where you'll find a whole wealth of interesting information on there about innovations. So what we do is we collect as many studies, randomized control studies that have been done around the world. And in this particular case, you'll see here we've got 1, 2, 3, 4, 5. And we put this information into a program which then plots where the average, where the weighting of those studies is in terms of favouring. And if it crosses this line here called the line of no effect, and the sum of all of these studies gives you this diamond here, which crosses over this line here, it tells you that, for instance, time-lapse is favourable compared with the standard treatment, which is the control. There's still quite a bit of controversy around this, about the choice of studies and the design of the studies. It's very, very hard to find really good quality studies that have been done around the world. So there's always debates, and there's always, if you go on and have a look at these meta-analyses, they often fall in these kind of grey areas where they say more studies are required. So it can take many, many years to come to a very black and white, firm decision on whether or not something is of benefit or not. And I'm just going to skip over a couple of videos here. I was going to show you a normal development and an abnormal one. This particular one was going to show us how an embryo can, instead of dividing immediately into a 2-cell, this particular one was going to divide immediately into a 3-cell. And we would have missed that in standard culture practices which we have at the moment, whereas time-lapse can show you that. One of the innovations which is very black and white and is absolutely of benefit to people who require it is the ICSI Revolution, which happened in 1994. It was of equal importance to the beginning of IVF, really. It was that much of an improvement. ICSI stands for intracytoplasmic sperm injection, or microinjection of sperm, same thing. And I was involved in introducing this into our clinic in 1994, as were other clinics. It was initially done in 1992 overseas, but in New Zealand we did it. We were a couple of years following. This is my colleague Tanya here, sitting at an ICSI microscope using the joysticks and joysticks here, and the microinjectors here, one holding the egg and the other one in chasing a sperm and catching it and tapping it across the tail, sucking it up into the pipette, and then injecting it into the egg, which is being held here. Very much like driving a digger, really. If you can use these kind of joysticks, I'm sure you could drive a digger. So it's a lot of a challenge, and very satisfying to do as an embryologist. But this was an absolute game changer in 1994. Prior to this, we were only treating women that had blocked tubes or ovulatory problems. If you had a low sperm count, really the only thing we could offer you was donor insemination. But for people who need it, it is absolutely incredible that we can achieve fertilization. And of course, it can be quite tempting to almost use it for everybody, because it's a guaranteed kind of way of getting fertilization. But it's really important for us as embryologists that we only use intervention where necessary, and we use it very judiciously. And for people who need it, it's incredible. But if you don't need it, if you've got normal sperm and it washes up very nicely in our wash-up procedures, then we'll always want to use standard IVF. But it still means that we're using it up to 50 to 60% of cases. There are other things that we can do. There's other add-ons that we can use, such as Pixie, where we could use a dish that is covered in hyaluronic acid, and that will help the embryologist select out sperm that is mature and ready to fertilize. We could use something called IMSI, which involves high-resolution eyepieces here and magnifies the sperm up almost 6,000 times, I think. And that allows you to have a really close look on the sperm. But all these things take extra time, and again, I think they have their place for people who need and who could benefit from this. And I'm going to cover add-ons a little bit later in this talk as well. I'll come back to that. Right, I'm just trying to advance the slides here and not having much luck. Here we go. So the next big thing that's become very popular over the last several years is testing embryos for normal numbers of chromosomes and structure of the chromosomes, called PGT, or pre-implantation genetic testing. It comes with all kinds of acronyms, and I really haven't got the time to go over those today. But the basis of it is, as you know, we've got 22 chromosomes plus the sex chromosomes here. And what we now know is that up to 50% of our eggs that we have in a woman's body can be, that we produce in IVF, can have an abnormal number of chromosomes. And that can increase with age. So why is that? Why are we so inefficient with our eggs? Well, the reason is that these poor old eggs have been hanging around since before we were born, waiting really to be ovulated and produce a baby. So obviously, the older that you are, the more chance that there is of chromosomes going wrong and separating in an unbalanced way. But what we can do is we can screen the embryos that we produce in the incubator and in the IVF lab, because we can't see the abnormalities with our eyes. What we need to do is take a little number of cells, up to 5 or 6 cells, out of a blastocyst stage embryo, which is what the stage we use now, which is the 5 to 6 day stage. This is holding a biopsy pipette here, which is sucking up about 4 or 5 cells here. And what we do is we take those cells and we send them off to the genetics lab to be screened using some very incredible technology now called next generation sequencing, where it will screen all of the chromosomes in those cells that have been biopsied. This is the kind of report that we get back here, and as you can see, here's down below is all the numbers of the chromosomes across the bottom, plus the X and the Y. And this poor old embryo here has got 2 copies of everything up until it's lost a chromosome down on chromosome 7, and it's gained one up on chromosome 8, which would be pretty lethal for this embryo. It could be perfectly normal looking, and when we put it back, we wouldn't know had we not done this kind of testing. So clearly it is of benefit to only put embryos back which we know have got a normal chromosome competency of them. And so obviously that's going to, for a woman, that's going to shorten her time to achieving a live birth. She's going to have less miscarriages. There's an enormous amount of data which is produced from this type of technology, which is called big data now. And again, artificial intelligence is helping us make the decisions about which embryos which have got normal competency of chromosomes. And obviously the artificial intelligence, it's more accurate than the human, particularly when there's cases where it's not clear, where we get a little bit more of a messy kind of a line than this, and it's a little bit less clear for us, but the AI will help us make that decision. So less errors, less subjectivity. But wouldn't it be fantastic if we didn't have to take cells out of the embryo? Because let's face it, that's pretty invasive for the poor old embryo, even though they're incredibly resilient and they cope very, very well with having those cells taken out of them. And thankfully that there is something hopefully on the horizon where we can be looking at non-invasive pre-implantation genetic testing. It turns out that every embryo does expel a little bit of DNA into the media that it's growing in. And they're little tiny fragments of DNA. We've known this for many, many years, and some very, very clever scientists around the world have been working during that time trying to come up with efficient ways of replicating up and those small amounts of DNA that we can get from the media, and then testing to see if that can correlate with normal chromosomes. And as it turns out, that there is a high correlation. But of course, there's lots and lots of challenges because of the tiny quantity, and also it's really subjected to contamination from the media and the environment. Currently, there is about an 85% correlation, and there are clinics around the world which are offering this as a service. But as scientists, we really, really would like to see that correlation up more, around about 95% sensitivity and accuracy. So I think that I've just come back from a conference from overseas, and I think most scientists are still feeling that that's just a little way away yet before it becomes routine practice. Okay, so I wanted to just cover the concept of add-ons and innovations, and what are they. You may have heard about it in the popular news recently. It's a little bit controversial. There's been some controversy about some less scrupulous clinics around the world that have been offering add-ons, making lots of money, asking patients to, recommending that many patients use add-ons, and often where there's a low level of evidence of benefit. So what are some of the kinds of add-ons that are offered around the world? Firstly, I want to say that this is I have great confidence that there's not clinics in New Zealand and Australasia that have been doing this kind of practice. New Zealand in particular have been world leaders in really championing safe practices. For instance, single embryo transfers. We're one of the first in the world to be doing this widespread. So we're very, very focused on providing things that have got evidence and are ethical. But some of the examples might be, for instance, culture media. We've known for many, many years that embryos are exposed to a huge number of growth factors that help them grow and communicate with the mother inside the mother's uterus. And of course, a lot of embryo culture media is devoid of that. So slowly we're starting to understand this more and add those growth factors back in. EmbryoGen would be one of those. And it's about growing confidence and experience in these kinds of culture media before we really truly know who it best benefits. Embryo glue has been considered as an add-on in some places. In the future, we're pretty much deciding that that's we feel it's an essential part of just routine practice, so we won't be offering it as an add-on. It's just hyaluronic acid, which is in the body. It's a natural component in the uterus, and really, high levels of it should be around at the time of embryo transfer. That just seems like a bit of a no-brainer, really. We've talked about IMSI and ICSI. Assisted hatching is one of the innovations which has been around for many years, and there are instances where that can be of great benefit, for instance, for egg freezing. And particularly women that have got eggs with thick zonas on them or shells around them. Time-lapse we've considered as an add-on, and there's lepiodol, which has been the poppy seed oil that you can put into the uterus to promote receptive endometrioms, and intralipids. So these are just some examples there of what can be considered as add-ons. But we feel that it is important that that patients know, clients know about what is available, and it's important that we inform them about costs and who it's best, the criteria for who is best going to benefit from these. And also there's places that you can go online now. For instance, the UK regulators, the HFEA website, you can go on and have a look at what their recommendations are for each add on. They have like a traffic light system that you can look at, although I will warn you, there's very little that's got a green light at this point, because as I've explained to you, a lot of it is still in the pretty much grey area, and there are specific groups of patients where these things will benefit and those that won't benefit from it. So, yeah. Now, I think that's pretty much all I've got in terms of strictly embryology-based innovations, but let me tell you, embryologists are also very interested in uterine receptivity, because let's face it, 50% of the chance of success lies in the embryo viability and quality, and the other 50% is really, have you got a receptive endometrium? And the endometrium, when you put the embryo back, is actually only receptive for a very short window of time. And what's becoming apparent as the years go by is that up to 30% of women who have an embryo transfer, unfortunately, their endometrium is not synchronized with the stage of the embryo. So there are ways that you can test this through an endometrial biopsy in a non-treatment cycle, where we take a small number of cells from the endometrium and we send it off for genetic screening now for up to 250 genes that are known to be associated with a positive receptive endometrium. And the result that we get back, the report that we get back, is something like this one at the bottom here, which will tell you when we took that endometrial biopsy, was your endometrium pre-receptive, receptive, or post-receptive? And that provides us with information for the next transfer cycle about when to time the embryo going back in. So unfortunately, of course, these things cost a lot of money, but if it wasn't for money, I think, everybody would benefit from this. And if money isn't an issue, then this is something that people might want to seriously consider. And the other final thing that I'll leave you with is a bit of a hot topic at the moment. As I said at the latest conference that I've come back from, a lot of people are now talking about this thing called your microbiome, and even throughout all different types of areas of medicine now, it's becoming apparent that we carry around trillions of bacteria in our bodies every day, good ones and bad ones. Up to 1 kg of our body weight can be bacteria. And not only is it just in your gut, but if somebody had told me several years ago that in fact we carry bacteria in our uterus, I wouldn't have believed you. I thought that our uteruses were and should be perfectly sterile. But we now know there's a lot of reports and research and evidence coming out now that shows that if you've got a predominantly lactobacillus species of bacteria in your uterus, then that's very positively associated with higher implantation rates. And there are certainly some real baddies that you can have in your uterus as well, which are very negatively associated with implantation. So I guess the good news is that there are some tests around now that we can get this tested for. And alongside the endometrial biopsy that I just explained, you can also have an add-on for this thing called an EMA test on top of your ERA test, where you can have the microbiome of your uterus tested. So again, pretty exciting, and that's where things are possibly going. What would be really good to know is how we could influence this, and who knows, it could possibly be through diet. So that's, I think, some of the exciting things for the future. And as you can tell, I could talk about these kinds of things all night because I'm really passionate about this subject. But I think that we've probably covered enough topics now to open it up to some questions if you'd like to. So thank you very much for your attention and checking in tonight. Thank you. I'll hand you back over to Juanita, I think, or she's going to provide me with some questions that I can read out. Right, so
Thanks, Debbie. There are a couple of questions there. Are you able to see those?
Yes, I can. Some are quite lengthy. It could take me some time to read it out. So here's a short one. How much is ERA and EMA roughly in terms of New Zealand dollars? I believe they're around about $2,000 to have the endometrial, the basic endometrial biopsy and ERA test. That's sent over to either Europe or possibly the United States. And then I think it's an extra $400 to get the microbiome test done. So, yeah, okay. And 2 people have asked that question, so that's fine. I've covered both of those. We've got somebody here who said that they've recently had 3 cycles of IVF in Brazil. And sadly on the first cycle she only had 1 follicle with 1 egg. The fertilization succeeded and got a healthy embryo, which is great. But you've decided to try more cycles to get more embryos, but no eggs on further occasions, unfortunately, which is really disappointing. Would you insist on considering continuing with more treatment? And this woman's age is 40. Yeah, that's a really, really tough one. And I guess after two attempts with no eggs, I guess what you've done is really maxed out the amount of stimulation that you've been able to take, I guess. And often in these cases, every cycle is different. But if you've had 2 or 3 cycles, then that's sounding pretty consistently like there's quite a challenge there for you. And sometimes it might be an egg donor is often recommended in these cases, but that's personally, something that your doctor will be able to really describe what your options are. So thank you for that, and I really wish you all the very best of luck with your future treatment or your journey. So good luck with that, guys. Yeah, let's see if I can find some more down here. What is the outcome of a negative EMA test? And what can you do with that? Yeah, as I said, that's the burning question at the moment. We're all trying to find, that's a hot topic of research at the moment. What can you do? Obviously, antibiotics is really not going to be particularly helpful. As we know, antibiotics often kill off the good bacteria in our bodies. And I think there was some presentations at the conference that I went to that actually confirmed that. Yeah, so let's hope that it's something as simple as diet. There are some lactobacillus tampons that you can actually purchase over. I'm not sure whether you can get them in New Zealand, but we've been looking at that. But you might want to look that up on the internet. And I'm not sure exactly how effective they have been. So that's something you could look at. Okay, what have we got next? Is there anything you would recommend for male infertility, and would you recommend any tests or anything further to assist successful treatment? For male infertility, gosh, there's lots of reasons for male infertility and lots of different aspects of the semen analyses. It could be low motility, low concentration. It could be due to some kind of trauma to the testes. probably the most kind of like the greatest lengths that we would go to would be to do a testicular biopsy to retrieve sperm. We definitely recommend antioxidants for low sperm counts. I'm a big promoter of being aware of your exposure to radio frequencies from things like laptops, working on your lap, cell phones in your pocket, long periods of time exposed to routers near your body, that kind of thing, that can elevate your reactive oxygen species, which can in your body, which can affect sperm. So yeah, just being aware of your lifestyle and what you're exposing your body to, and then taking antioxidants where necessary, or eating foods high in antioxidants is kind of really pretty much the best that you can do. But again, doctors really, fertility specialists are absolute experts in this area, and they'll be able to give you some really, really great advice. But yeah, in terms of male infertility, we are a lot more interested in it these days and coming up with some solutions there. So yeah, good luck with that. What would I suggest after 7 failed cycles that include 2 biochemical? Certainly, when there's been biochemicals and failed implantation, looking at endometrial receptivity is one thing you could look at. Certainly, pre-implantation genetic testing is another of your embryos, and also making sure that you've checked your own karyotype as well and your partner's karyotype, and making sure that you don't actually carry any chromosome abnormalities either, which might be contributing to that. So as long as you've explored all those kinds of options, then those kinds of things are out there and available to you. Good luck with that. Is it better to check the embryos only on day 1 and day 5 rather than every day? We certainly try to reduce the amount of time that we look at our embryos in our current practices, where we do this kind of snapshot grading system, which we have available to us at the moment. We want to be getting the embryos out as least as possible, so they're as less disturbed as possible. But that is one option, only looking at them on day 1 and day 5, and some people actually do ask us about that, and we can do that. But we do feel that there is some information that can be provided on day 3, particularly if we consider that a day 3 embryo transfer is best for that couple. So in fact, every individual is different. It depends on how many cycles they've been through. All kinds of things are factored into that, why we would look at them on different days. But just so that you know, we definitely try to minimize it as much as possible. And of course, time-lapse machines, that is what happens. You only put them in and disturb them once at the beginning and once at the end of their culture. But traditional practices, you need to be able to say to a couple, depending on how many eggs they've got, whether or not it's best they have a day 3 transfer or a day 5 transfer. So yeah, thank you for that. Just working down my list here. Thank you very much for everybody who's said they have enjoyed it. Is high embryo grading correlated with pre-implantation genetic testing of a normal embryo? There is, but it's quite weak. So we know that there is a certain proportion of beautiful high-grade blastocysts that we see on day 5, which are still have got an abnormal number of chromosomes. So it's not fail-safe. We do know that high-grade embryos have a higher chance of being normal, but not completely. So yeah, thank you for that. And that was, again, somebody else asked how accurate is the embryo grading. It's not that accurate using our traditional morphological basis where you've got the snapshot approach. I would say morphological and morphokinetics, which means using the exact time frames of when the embryo hits certain milestones. If you can add that in, that's a lot more accurate at predicting viability of embryos, and that's where the time lapse is of benefit. So thank you for that, Jasmine. And Renata? Yeah, again, somebody else has said that they've had 7 embryo transfers from 3 IVF cycles, including a donor egg cycle. So here's somebody who's really, really covered a lot of options there and still been unsuccessful. Gosh, without knowing your details, it's hard to know what your best way forward would be. And a lot of that's going to depend on people's age. So many factors can be taken into account there. So yeah, good luck with that. Very best of luck. Yeah, it's probably not appropriate for me to give you any advice there other than to say my heart goes out to you and good luck with anything you choose to do. Somebody said, yeah, he's somebody who said they really like to be an embryologist, and how do you become one? Well, traditionally, we've embryologists over the years have learnt on the job and become part of a training program of a clinic. But these days there are some fantastic master's programs that you can enroll into, and some of them are actually can be correspondence. There's very good ones in the UK, and there's excellent ones in Australia. Sadly, they do cost a lot of money these days, up to $30,000 to train. But gosh, it's been the most amazing career that I could have chosen, and yeah, I encourage you to pursue it if that's what you find you're passionate about. Yeah, good luck with that. If there are 2 good embryos, would they ever be implanted together if there's twins in the family? Depends on what kind of twins, I guess, if they're identical or non-identical. So there is a hereditary aspect to both of them, but women that have non-identical twins in the family, obviously that's double ovulation of 2 eggs in the same month, and they can be likely to do that again and again. And if it's identical twins, then that's from a single embryo that's split into 2. And interestingly, that's slightly a higher risk of that if you're having, for instance, frozen embryo transfers and some other types of IVF as well. So yeah, now is it, the question was, yeah, if you're looking at putting 2 IVF embryos back and wondering whether or not you're going to have a higher chance of having twins because it's in your family, then I'd say the answer is no. The fact that you're putting 2 back at all increases your chances of having twins, obviously. And that leads to higher risk pregnancies, and that's why routinely we only put 1 embryo back in IVF. Thank you for that. Is it correct that sperm quality affects the embryo quality? That can be the case, absolutely. We can see couples coming back time and time again where we suspect that the sperm quality has affected the embryo quality. So that can be the case. How do twins develop from a single 5-day-old blastocyst? Well, that can happen because the embryo, as it's hatching out, or even later on after it's hatched out, the inner cell mass, which is the little part of the blastocyst that becomes the embryo, that can split into 2 segments. And in fact, we just saw one of these the other day in our laboratory, where we noted that the inner cell mass had already split apart prior to transfer or freezing. So yeah, that's how identical twins are created. And sometimes when they're hatching out of the shell of the embryo, they can get split into 2 as well. Yeah. Roughly how much is it to test frozen embryos, and what are the risks around these? We do, in fact, where couples have had, or individuals have had, many embryos frozen, and they decide that they want to have PGT, pre-implantation genetic testing of all of them, so that that can reduce down the number of transfers that they need to get a baby. We certainly quite routinely perform that, and it's amazing what these embryos can put up with. We can thaw the embryos, grow them out, biopsy the embryo, freeze them again, get the results back, and only transfer those that have normal competency of chromosomes after having thawed them out again for the second time, and plenty of babies from that. So it is incredible how resilient these embryos are for freezing and thawing. We can do that quite routinely, freeze and thaw twice. So yeah, that is possible. And so roughly, it depends on where you go. It could be up to $400 or more for each embryo to get tested for PGT. So it's pretty costly, but for some people that's very, very worth it. And I can see Juanita has come back on, and probably that indicates that it's time to finish off the questions. So,
yes,
am I right, Juanita?
Great questions, really good questions.
Yeah, I'll say.
And thank you again, Debbie, for a really informative talk and discussion. And it was really interesting to go back into the history of embryology a bit, and to it's always useful to look to the past when we're looking to the future. Especially in such a complex area, there's so many factors and variables at play. So it was a really useful session, and thank you all for attending. We do have other webinars, of course, through to the conclusion of Fertility Week. Tomorrow evening session at the same time, 8 p.m, is called Calling It Quits. One of our local fertility counsellors will talk through just how to make the decision to end treatment and go forward with life from there. So it's always a confronting but useful session. So I hope you'll all join us then. Thank you again, Debbie, for your time, and for everyone else for joining in. And thanks again for supporting Fertility Week.
Okay, thank you. It was a lot of fun and a pleasure. Thank you. Good night.
Good night, everyone.